Fuchs heterochromic iridocyclitis, unfortunately named after the same guy that Fuchs endothelial dystrophy is. So students very frequently get the two confused, and sometimes just confused because somebody will say Fuchs and not continue that. If you just hear Fuchs, period, probably talking about the endothelial dystrophy. Much more common, has nothing to do with this, but you'll see that pretty regularly in clinic. The heterochromic iridocyclitis, not nearly as common, but if you do come across it, it's just that. A heterochromic iris, you have the two different colored eyes. The lighter colored eye is the one that's being affected because the chronic inflammation in there will damage the iris pigmented epithelial cells and then lighten up over time. Much more common would just be a natural heterochromia where an individual has a lighter colored eye, just that's the way they were made. But if you have a patient that has the heterochromic look and the IOP is significantly higher in that eye, start looking around and you'll probably see just this low grade sullen flare, low grade amount of inflammation inside the anterior chamber. And then that chronic inflammation can also cause that IOP going up and you end up with a glaucoma situation. So as far as what's causing it, don't know. Any kind of inflammation, we think maybe some autoimmune. The unilateral nature of that makes that less likely, but still possible. Also, maybe an infection. It's been linked to toxoplasma. It's been linked to rubella. People with active German measles actually have something similar to this or can have something similar to this. And doing Ig titers, immunoglobulin titers, that's borne out somewhat. So it may actually be caused by a few different things, like so many of our conditions, but that's the theory as of now. As far as treating any high IOP, we're going to use standard glaucoma meds, something like a timolol or an alpha-GAN. Prostaglandin drops, a Zalatan, a Lumigan type drop, probably won't be effective just because there's no prostaglandin receptors to be had. There's that chronic inflammation going on. There's plenty of prostaglandins floating around in the anterior chamber. Uh, Again, the inflammatory component of the prostaglandin drugs is overblown. It probably won't exacerbate the inflammation. It's just not going to have the IOP lowering effect that we want. So again, something like a timolol, a beta blocker, or alpha agonist. As far as any kind of surgery, an SLT usually doesn't work because that TM is often covered with those fine blood vessels. It's not very effective. Uh, it's maybe okay to try it, but I would not expect much. If drops cease to work, then you're probably going to have to go to a more invasive surgery. And then as far as steroids, I put the note there that they don't do much. And that's true with that chronic low-grade background inflammation. That's always going to be there. Steroids never make that go away, at least completely. These folks do have acute attacks, acute inflammatory attacks, more of an active uveitis, iritis, more active inflammation. And for those, the steroids do help, and you do want to put them on. And it takes a while to beat that inflammation back. Sometimes you'll have to have them on a steroid for several weeks to even a month. And of course, we have to worry about the IOP then as well. But as far as just day-to-day low-grade inflammation, we're not going to use a steroid for that.